peer-based drug user organization. So all the wellness people have gone to the loo now because I just spent the past hour telling them who we were. So a peer-based drug user organization means that we're staffed by people with lived experience of drug use. So that can be people that have used or are using drugs, and we focus on harm reduction. So we focus on people that are using to help them use more safely. A big core focus of our work, the primary funding for NUAA is under the hepatitis C strategy. So a lot of our work is on safer injecting and access to hepatitis C treatment. We do that, we do that via a fixed site NSP and also through outreach education programs.
Mary, do you want to kind of pop that up on view and stand here, or do you want
I'll probably stand. Oh, does it have like a...
do you need a...
No, that's okay. I'll stand here behind the safety of the podium. So I was overseas when we were arranging this, so I didn't appear in your program actually, and I just took the title that they gave me. So I've kind of been through this first slide of who NUAA is. I guess the one point that I'd highlight from this slide is we're about health and human rights, and we do a lot of advocacy. So we participate in an awful lot of committees. And I didn't make it into your program. So this is my bio that I would give out for events like this. I'm the CEO of the New South Wales Users Organisation. New South Wales Users and AIDS. Sorry, I've just spent like a whole heap of time doing speed dating, and now I find that I can't talk when I have to. So I'm the CEO of the New South Wales Users and AIDS Association. I joined in January 2015. My previous role was at the Kirby Institute, where I have a previous career in public health research, and more recently was working on an Aboriginal community-controlled health project, working with 5 services around the country, where we were working in bloodborne virus and sexually transmitted infections. I'm on a number of national advisory groups, so the National Ministerial Advisory Group. I have a PhD in psychology, and my focus is on viewing AOD service provision through a human rights lens and ending the war on drugs. But I have another side to my story, and that is that when I was 23, I found myself pregnant. I was dependent on heroin, and when I went to access treatment, I was told that I would either have to give up my child or give up my child. Those were the choices that were presented to me. That was, it was a number of years before I sought treatment at all. At that point, I ran away from treatment. I did go through a managed withdrawal program in a hospital, and then I didn't really seek treatment after that. I moved to Australia. I've had, like, this side of my story, like everybody, is a lot longer and more complex than this side of my story. But this side of my story has really informed my work and is a very current part of why I do what I do today. And it's what I mean by we're a peer-based organization. I don't know the drug use history of everyone that works for NUAA. I don't think everyone does have one, but that's the point of view that we come through of empathy and understanding. So when we're exploring these issues, like when I go to a GP myself, I make decisions in each situation about whether I will be safe in that environment, whether I'm going to be listened to and respected, whether I'm being judged or not, and those things will really inform on whether I receive the health care that I need. So if I feel that I'm being judged or not listened to, I'll walk out the door, I'll make an excuse, I'll leave. And that's that's true for many of your patients, I would imagine. Not your patients, but many people seeking health care. And the other key thing that I look for is whether I'm given choices, you know, whether I'm given the opportunity and the information to make my own decisions and take charge of my own health care. So any time the answer to any of these questions is no, access to service is reduced. The point of view that user organizations and drug users come from is one that prohibition is a large part of the problem and a large part of the harm of drug use. Because it's illegal, people are, and particularly the people that are most disadvantaged in society, will experience the most legal issues. They'll be arrested more frequently. And a lot of the harms of drug use actually come from it being illegal. Not all, but a lot of them come from its status as being illegal as opposed to the actual drug itself. And one of the very real consequences of prohibition is that access to medical care is limited, and how that impacts on your human rights. We have anti-discrimination laws in place, and you know, this is an actual headline from not that long ago, a couple of years, you know, there's a lot you could say about a headline like that. So obviously, there's a lot of towns that have problems with discarded syringes, but if you go in and delve under those issues, it's not a one-sided story. It's not about somebody being a scumbag junkie. It's about policing. It's about inadequate access to disposal facilities. You know, sometimes it's you know, if you can get targeted by police if you carry your equipment with you, so you leave it where it is. It's words like that that make it very difficult for people to seek access to care, and it sort of colors your whole perception to the system, and that's what my talk is about. So if you are viewed by society and you view yourself as evil, then how do you then open up the discussion and disclose your drug use so you can get whatever support and help you need? Oopsie. So we tend to frame in drug user organizations as a question of stigma and discrimination. And stigma is the thoughts behind the action. It's framing somebody, you know, because we're so used to thinking of drug use as evil. That's actually enshrined in the UN conventions, and the war on drugs as, like, in some ways, a fight to liberate people from drugs. We have certain conceptions about drug use that many people hold, you know, even people who use drugs have them kind of deeply ingrained, and that's stigma. And discriminations is how you act on those beliefs, and the way you treat people. This is not in any way rocket science or complicated. It's about empathy and openness. So the way that tends to work is stigma will lead to stereotyping and labels, and you'll be treated in a particular way by services, and then you act to meet those services, and you internalize those beliefs, and that feeds the whole cycle. So a really good example of this is a lot of opioid substitution clinics or treatment clinics, pharmacotherapy clinics, even in Sydney, even in Southwest Sydney, look like you're entering a prison. There's steel bars, there's plexiglass, there's, you know, barriers, real physical barriers to treatment. You can't have a one-on-one personal interaction, and that sets up a dynamic with the people that are accessing those services that's like very negative from the get-go, and that feeds a cycle of stigma and discrimination. You know, healthcare discrimination can take many different forms. You know, examples that I've heard of are people that have hepatitis C being like color-coded in a hospital setting, I've heard stories about people that walk into emergency departments on the weekend and are told that we don't, oh, why should I have to deal with a junkie on my Sunday? I did a radio program where people called in, and a gentleman told a particularly gut-wrenching story of where he was trying to support a friend of his for access to alcohol treatment, and was told by whoever was staffing that emergency department that we don't deal with those people. Was told that message twice, and their friend, you know, I think that my memory is that they killed themselves a week later out of despair at not being able to find support. And it is hard to find support. So, you know, having those, I mean, you know, another example is going into a service and being treated as where you're nothing but a drug user. You don't have other, you know, you might be going in for other needs and just having only your drug use dealt with. And those kinds of experiences will make people very wary of services. They might make them prickly or spiky and defensive, and the end result is they limit access to health care. And stigma is a genuine problem. It kills people. People die from stigma. You know, and to reject that model that is so pervasive, you know, the statistics tell us that 80% of people who use drugs that go into services experience stigma and discrimination, and that includes GP services, and that's 80%. That's why it's so fantastic to see so many people at a forum like this trying to change the dynamic. And fundamental to changing that dynamic is approaching that person who uses drugs as a person, like seeing the other side, not judging. Seeing drug use is, in many cases, as those scenarios earlier in the day quite nicely illustrated in a lot of instances, that it's a choice people are making for particular reasons. You know, treating people with respect and understanding their choices, using a framework of harm reduction, which is essentially the element of that is meeting people where they're at and supporting people in what choice they need to make, but most importantly, keeping people safe in whatever choice they're currently making. You know, the most widely spread example of harm reduction in Australia is the incredibly successful needle and syringe programs, which you know, mean that drug users in Australia have a rate of HIV that's around comparable with the general population, whereas in places, including the USA, where needle and syringe programs aren't so common, they're about, you know, anywhere from 10 to, you know, 50% or more of people who inject drugs have HIV. And another really key point that I'll talk about is language. I think this slide I've kind of covered, but like if 80% of people experience stigma in healthcare settings, there's a real role for leadership in healthcare providers to break this cycle and understand the reasons people use drugs, understand the humanity of people that use drugs, and treating people with compassion. So these, I've kind of given examples with the 5 A's of all of these things in this part of the presentation. So in terms of asking people about drug use, it's about rejecting the assumptions that are so often made about drug use. So, you know, talking about drug-seeking behavior when people are seeking pain relief, denial. You know, there is a resource that we were handing out, a language resource that I'll have a little bit of a look at in a moment. And there are a lot of assumptions inherent in that language that need to be examined more closely. So we have one example of somebody that in one of the consults we've done recently was somebody that came in seeking treatment, and the doctor that she presented to, the first thing that they said was, "I'm not giving you any pills," based on what she looked like. She wasn't going in for pills. She had another healthcare concern, but they just treated her as, you know, a stereotype, and she did not receive access to healthcare that day. And it made it, the next time that woman, if she does go into a doctor, it's much, much harder for her to do so. Once that precedent's been set, you just get discouraged and you don't want to go in. So any assumption about the people that are coming to you is in effect a judgment. And once you make an assumption, you're making a judgment call, and even if they still seek access to treatment, they're forced into a position of advocating for themselves that makes that bar a little bit higher to accessing treatment. And many people in our community experience a lot of self-internalized shame and stigma, and it's very hard to advocate for yourself in that position when you feel that way. And a key part of lifting that judgment and the assumptions is being very mindful about the language that you use, and judgment that's inherent in some treatment models. So language has tremendous power, and the way that people and issues are defined and in the context is very important. And the language that we use is vital. This is a resource that we developed with NUAA, which is a network of alcohol and other drug agencies. So they represent non-government organizations, rehabs, resi rehabs, a lot of them in New South Wales. And it gives examples of preferred and non-preferred language. So one of these is, that I think you can see is addiction, right? Which is, I think, is a bit of a controversial, you know, the concept of addiction is a catch-all that's used by many, many people that use drugs. I'm a drug addict, you know, and using an alternate term, people experiencing drug dependence might seem like you've seen some of the presenters today use that quite easily and naturally, but it's not the preferred term. Addiction is by far the most used term. It's kind of like, why not use addiction? Some of the terms are more obvious, like don't call people junkies is a little bit obvious, but you know, addiction as a disease model concept tends to put people in a category. It is a set of symptoms rather than describing a person. It's not a phase in someone's life, which drug dependence is quite often. You know, it's something that you may experience in different points of your life. Somebody that uses drugs is not necessarily an addict. It tends to get overused. And it's these kind of resources and that are available will help explain and clarify, like, the power in language. In terms of assessment, people who use drugs, I would very much encourage you to look outside the drug use for other healthcare needs. A lot of people, when they go to get, for example, are on opioid replacement therapy or opioid treatment, will only have that one healthcare need looked after. You know, I think it's understanding and believing that people that use drugs actually have multiple needs and do want health care. Like, they do want to, we proactively want to look after our health. We want to have treatment for Hep C. We want to have our health care needs looked after, but so often that's hard to access. And it's also important not to use drug use as a reason to effectively deny other health care. Like, you have to look after this before you can access that. Advice, I think that, you know, treatment can be complex, accessing it. For example, if you're a woman with children, you may be very reluctant to front up to drug treatment services because of stigma and the possibility that your drug use will be used against you in a number of ways to have your children taken away. That's a really prevalent issue for women that use drugs, for example. You might be reluctant to access treatment because your employer may have access to your medical records and it may harm your employment. You may be using drugs for mental health issues and be very reluctant to address drug use or look at it because it helps you. You know, it's actually a positive thing. In terms of assistance, the one message that we have again and again and again is information. I want information. I want unbiased information. I want to be empowered to make my own choices. And I would say in that regard that judging people's choices is not helpful. So, you know, saying you've got to pursue abstinence is not going to help a lot of people. It needs to be people pursuing their own choices. Sorry guys at the front, I'm having a really hard time concentrating, the people that are talking at the front. I'm really struggling. In terms of arranging access to treatment, there are, this goes back to assisting. There's a number of circumstances that make accessing treatment very, very difficult for people. So if you go back to the example I gave you with myself, where this was a long time ago and in a different country, but when I was looking for some kind of treatment when I was pregnant, and the choices I were given were, you know, if you withdraw without support, you might lose your child. If you go into a treatment program, you might have your child taken away from you by social services. It's choices that are not choices. They limit what your choices are. You know, AOD treatment in Australia is unfunded. We have about half the number of places that we need, so it can be very difficult to organize and arrange treatment. And even when there are places available, there might be barriers set up within those, like you have to ring on 3 o'clock on Tuesday is not at all uncommon with people trying to access services. You know, people who use drugs are seen to be unwilling and, you know, having to prove themselves at some level to access services, and that's just another barrier that gets put up. There's other barriers, like a lot of services won't admit people if you're homeless. You know, this is one of the areas where we advocate for increased access to services. If you're a woman with children, you know, there are very few places. If you're a man, a single father with children, there's no places. I've spoken to a lot of you about NUAA. That's kind of the end of the talking part of my presentation. So I said at the beginning that we're a peer-based drug user organization. These are our key areas of activity, needle and syringe program. So if people need injecting equipment, you can refer them to that. That's in Surrey Hills. We have peer education projects. We have peer projects that support people to access Hep C treatment. We have a consumer academy which supports people to participate in alcohol and drug advisory groups. We have a new intervention this year which is festival harm reduction. We do a lot of advocacy. We have publications and websites for NUAA, and our publication website is Users News, and we also do a lot of research collaborations, so we're participating in a Hep C treatment project, a naloxone project, etc. Oops. That would be my overall message to everybody. Just be nice to people, and it goes a long way to supporting their access to health care. I had one other with contact details, but I don't see it. Okay, thank you.
Thank you, Mary. Does anybody have any questions? Anything they want to add? No? Thank you so much for coming on this afternoon and speaking. It's such an important aspect that sometimes we can forget. I certainly know in the drug and alcohol service that I work in, my work is enriched and my experience is enriched by the consumer advocates that I work with. But more than anything else, my life is enriched by the people that I see, the patients that I see, and it feels like an absolute pleasure and delight and privilege to work with the people that I work with who have drug and alcohol issues.